Hi everyone and welcome. I am Dr. Jillian Teta. I'm a naturopathic physician from the United States, and I want to spend a little bit of time today talking to you about small intestine bacterial overgrowth, which is abbreviated as SIBO. So you may not have heard about this condition. It's been known about since the 1990s, really studied in earnest only in the last decade or so. And so you, or more importantly, your doctors might not be aware of this fairly prevalent condition. So today I want to break it down for you. We're going to talk about small intestine bacterial overgrowth in several chunks. First, I want to tell you what it is, and then we're going to talk about the symptoms of small intestine bacterial overgrowth. I'm going to talk about the risk factors for it, how to test for it, and lastly, and most importantly, we will cover how to treat small intestine bacterial overgrowth. So thank you so much for listening along, and I hope that this is very beneficial for you, and I hope that this can help many of you who are watching. So, small intestine bacterial overgrowth is simply, or not so simply, an overgrowth, a high population of bacteria that reside or have colonized the small intestine. Interestingly, they don't belong in the small intestine. Our healthy, normal, beneficial bacteria belong only in the large intestine. Our large intestine, or our colon, houses what's called the microbiome, which is this vast colony of beneficial bacteria that do innumerable functions for us, ranging from digestive help to helping us manufacture nutrients, to helping with immune function, to helping with hormonal balance and detoxification, to all different types of things. So these guys are very important and they belong in the large intestine. Now, if some of them overgrow into the small intestine, or different bacteria crop up in the small intestine, if they reach a certain threshold, well, of course, they're doing their bacterial thing, right? They are fermenting, they're metabolizing, and these create symptoms, okay? So this is a colony of bacteria that is where they don't belong, doing their bacterial thing, whether they're normal gut flora or harmful flora, okay? So these guys are there and they don't belong there. To make matters worse, and this is important because this is going to come into treatment later, because they are in the inhospitable environment of the small intestine, these bacteria form something called biofilms, okay? A biofilm is a literal fortress that these bacteria or other microorganisms make to protect themselves. They use polymers that they are making themselves, carbohydrates, and even metals and other materials from your body, okay? And they literally create a fortress to protect themselves. This can make treatment a little bit tricky. And in fact, biofilms are responsible for, well, treatment failure in some cases. And later we're going to talk about how to overcome that. Okay, so the important thing to know is that these are bacteria that are doing their bacterial thing where they don't belong, and they are creating a defensive structure against your body and your immune system, and also against antimicrobial treatment, like antibiotics and such. Okay, so what are the symptoms of small intestine bacterial overgrowth? This is a very interesting question, and this is where it can get really tricky. I call small intestine bacterial overgrowth the great clinger, okay? So what this means is it is virtually indistinguishable from an enormous variety of other gastrointestinal conditions. Okay, the symptoms are very similar to many other gastrointestinal conditions. To make matters worse, they also ride along with many other gastrointestinal conditions. So, some of the symptoms look a little bit like this: gas, bloating, distension, particularly after meals, reflux and heartburn, sour stomach and indigestion, constipation, diarrhea, and alternation between the two. Additionally, we can have effects outside of the gastrointestinal tract. Typically in 4 areas we'll see this. Skin changes, right? Rashes, patches, increased acne, itchiness, these types of things. Muscle and joint pain, brain fog and fatigue, right? Just not feeling as sharp as we normally are. And then mood changes. Feeling really down, feeling depressed, feeling irritable. Even though the problem is in the GI tract, you can have other symptoms in all these areas. And if the issue goes on long enough, you will begin to see signs of malabsorption. You could potentially see anemias, you could see fat in the stool, and then you can have things like osteopenia and osteoporosis, which is like the thinning of the bones, and other signs of immune overactivation, like increased immune activity, increased inflammation, and autoimmune markers and disorders might start coming up. So this is not a casual thing that we want to ignore. This is definitely something that we want to address. Now, things like constipation and gas and bloating and fatigue and brain fog and acne and joint pain, these are very common symptoms, right? We could sit here and develop a list of dozens of different reasons for why you might be bloated or why you might be constipated, right? So this is why SIBO is tricky, because these symptoms are extremely generalized, meaning they can be explained by so many other things. They're highly likely to be dismissed by your medical provider. Well, you don't have SIBO. First of all, I've never even heard of that. I don't even know what that is. But you have IBS, right? And speaking of IBS, some of the risk factors for small intestine bacterial overgrowth include a prior diagnosis of another gastrointestinal disorder. So, for example, 85% of people that have IBS, irritable bowel syndrome, nervous bowel, whatever you want to call it, also have small intestine bacterial overgrowth. Small intestine bacterial overgrowth clings to these other conditions, and we'll talk about why that is in a second. Other risk factors for small intestine bacterial overgrowth, in addition to IBS, include inflammatory bowel disorders like Crohn's disease and ulcerative colitis, also microscopic colitis, which includes 2 different types, collagenous colitis and lymphocytic colitis. Also, you have gallbladder issues. So if we are having a history of gallstones, if we've had our gallbladder removed, this also increases risk for small intestine bacterial overgrowth. Chronic pancreatitis, ileocecal valve dysfunction, even things like interstitial cystitis and painful bladder syndrome, all of these conditions predispose one to small intestine bacterial overgrowth. It clings to them, okay? This is also why it can sort of masquerade and hide. So it will hide behind these prior diagnoses, okay? That's very important to know. So if a good hint for you is if you have one of these diagnoses and you're doing everything that your doctor is telling you and you've cleaned up your diet and you're taking all the right supplements and you're doing all the right things and you're not getting better, or you're only getting marginally better, it's not because that you're doing something wrong. It's because all of the pieces of the puzzle may not be there yet. And small intestine bacterial overgrowth is a big piece of the puzzle that I don't want you to overlook. All right? So other risk factors beyond other conditions that we might have are certain medications. Okay, so certain medications will increase our risk for small intestine bacterial overgrowth. These are acid blockers, right, like proton pump inhibitors, these types of things. Also opioids, prior history of antibiotic use, and also birth control pills. These all increase risk for small intestine bacterial overgrowth. Then we have a final category of other things that will increase risk. These include resection of the bowel, right? So if you've had to have a piece of your bowel removed, that surgery can increase risk. Also bypass surgery, really truly any type of abdominal surgery. And interestingly enough, a traumatic brain injury or a concussion can also increase risk for small intestine bacterial overgrowth. Other hints that small intestine bacterial overgrowth may be present if your symptoms get worse when you take probiotics, or if your symptoms get worse, especially constipation, when you increase fiber. Those are really big hints. If you've been diagnosed with celiac disease, which is another condition that SIBO overlaps with, and you went on a gluten-free diet and your symptoms aren't improving, that's another major hint for small intestine bacterial overgrowth. Also, interestingly, if you've been prescribed an antibiotic and it temporarily improved your symptoms, but then sort of backslid, that is another interesting case for small intestine bacterial overgrowth. All right, so a lot of risk factors here. Underpinning all of this, the reason why small intestine bacterial overgrowth is able to set up shop in the first place for a couple different reasons, okay? And this is very important to understand. These bacteria really can only colonize when the small intestine has slowed down, all right? Normally, in a normal, healthy small intestine, there are rhythmical waves that pass through, say, every 60 to 90 minutes. It's called peristalsis. And what these waves do is they propel food and potentially bacteria and other microorganisms that you might have inadvertently swallowed down and towards the large intestine. If this slows down, you have a higher chance in this low motility state to have colonization of bacteria. They can adhere easier to the small intestinal wall and they can do their bacterial thing. This dysfunction is a major piece of how it develops. This is called, it's damage to the migrating motor complex, okay, or the MMC. And the MMC is part of your second brain that is sort of organizing and managing and monitoring digestion and motility. So when that MMC is dysfunctional and the small intestine stops or slows greatly, that becomes a major problem and a major risk factor. And interestingly enough, in cases of IBS and even inflammatory bowel disease and gallbladder disease, that is exactly what is going on, is that second brain piece, that MMC, becomes dysfunctional and slows down. All right, so a slow intestine is extremely important for the development of that. All right, and that's going to come into play with treatment when we talk about treatment in a little bit later. Other things that are going to increase risk is a further breach of our defenses, okay? So motility is actually a major defense against bacterial colonization, adhesion, and overgrowth. But we also have other defenses built in. For example, our stomach acid, right? Even though I know, like, as a society, we are sort of conditioned that stomach acid is bad and you never want it to get too high and we need to take acid blockers and all of these types of things. Stomach acid helps promote regular motility of the small intestine and is a very powerful antibiotic, right? The pH of stomach acid is extremely low, between like 1 and 2, right? Very, very acidic. So bacteria really have a hard time, pathogenic bacteria have a really hard time surviving at such a low pH. If we are taking lots of acid blockers or we're advancing in age and just not producing as much acid as we did before, then that's one of our defenses that is lowered. Likewise, our digestive enzymes that are made from the pancreas also promote motility and are mildly antimicrobial. Lastly, our bile, right, created by the liver, stored by the gallbladder will squeeze itself and release bile into the intestine when we're eating. If you are not appropriately releasing bile because maybe your gallbladder is removed or you're having liver issues or gallbladder issues, then you also lose that piece of defense as well. So your bile is also a powerful antimicrobial, just like acid and enzymes, and also just like acid and enzymes, it helps promote that motility, okay? So the entire reason, just to recap, because this is important, the entire reason that small intestine bacterial overgrowth can occur is because there has been a breach in the defense of our gastrointestinal system. And that mostly looks like the small intestine slows down and we lose the benefit of acid, enzymes, bile, or a combination of them. All right? And then we can link that to those conditions that we mentioned earlier are enhancing all of those risk factors, right? Again, IBS, IBD, they're all associated with a slow small intestine environment. And then there's many medications, surgeries, and other such things that will reduce our output of acid, enzymes, and bile. So now we have a perfect situation where bacteria can kind of settle in, snuggle against that small intestinal wall, adhere there, and begin to multiply and colonize and create biofilms. And then we have small intestine bacterial overgrowth. The symptoms begin or worsen or have already been there because you already have this prior diagnosis, right? So then our doctors are scratching their heads because, oh, well, you have IBS. All these symptoms are due to IBS, right? So we want to unmask small intestine bacterial overgrowth, all right? So how do we begin to unmask it? I want to talk a little bit about testing now, testing options. And I'm going to talk about testing options in the United States. I am not sure if the exact same testing methods are available abroad or in the United Kingdom, but I cannot see why they wouldn't be. So, a couple different things to think about with testing. I'm going to have a sip of my tea here. First, the most common and widely acceptable form of testing for small intestine bacterial overgrowth is a breath test, okay? What we do here is we swallow, well, actually, let me back up. First, a breath test essentially is over a period of 2 to 3 hours, you are going to be giving individual breath samples into a little tube, into a separate individual little tube. So, at the beginning of your test, you take a baseline breath, then you swallow a sugar solution, which is either glucose or lactulose, and then at timed intervals, usually 20 to 30 minutes, you blow into a fresh new tube, and they're all labeled, right? And so then by the end of your 2 to 3 hours, you have lots of samples, okay? And then those samples are sent off to a lab, and they are analyzed for their content of two gases, hydrogen and methane. Hydrogen is released by a wide variety of bacteria. It is a metabolic byproduct of bacterial metabolism. Methane is produced by a smaller amount of bacteria, but they are still significant, all right? And these are called methanogens, right? This just means that these are bugs that make methane. There's also another type of microorganism that's not bacterial that are called archaea, and they also make methane as well. I mention archaea and I mention other types of non-bacterial organisms because this is going to come into play during treatment. All right, because, well, we will get there, but just know that small intestine bacterial overgrowth can also include non-bacterial organisms as well, including yeast, fungus, archaea, and so forth. All right, now for interpretation. When your lab tests come back, it's going to look like a graph. A normal result would be that levels of methane and hydrogen are stable and steady throughout the whole test, and they're low. This would indicate that there's no bacteria in your upper GI tract. If, however, there is an increase in hydrogen of greater than 20 parts per million from baseline, or 10 parts per million of methane from baseline, that is considered diagnostic for small intestine bacterial overgrowth by the North American Consensus Group. All right? You don't have to have both positive. You can have either or. False positives, meaning the test says you have it when you really don't, are rare. What is more common are false negatives, where the test says you don't have it, but you actually do. So, how do we know if we should use glucose or lactulose as a testing medium? There's actually not, at this time, which is January 2019, there is no firm consensus on which test is superior. But I would like to share with you the test that I prefer and the reason why. All right, so glucose is a sugar that is absorbed in the proximal intestine. So what this means, and a proximal small intestine, and what this means is that it is absorbed closer to the stomach, all right? Our small intestines are long, or 20, 30, and then some people even closer to 40 feet long. All right, this is a very long, long, long organ. Okay, small intestine is named for its diameter and not its length. All right, so glucose is absorbed higher up, closer to the stomach. Lactulose is absorbed more distally, which means further away and closer to the large intestine. So lactulose makes it to that last portion of the small intestine called the jejunum. Now, if we're thinking that some small intestine bacterial overgrowth can come from the large intestine, of course, it's going to be working its way into the jejunum first. So in my thinking and in my clinical experience, I use the lactulose testing medium more frequently because I feel like it captures a wider net. It casts a wider net, and it's going to capture more cases of small intestine bacterial overgrowth. The data point to this as well. There are fewer false negatives when it comes to the lactulose test than glucose. So for me, this is my preference. I prefer the lactulose medium. In the United States, a lactulose test does require a physician to order it. A glucose test does not. So in the United States, you can get glucose testing sort of like buying it online from a laboratory and do it yourself. Lactulose, there's no such luck, which means you're going to have to go to a physician to get this test. I do think it's a worthy pursuit, however, to go to lactulose testing. Again, simply because you have a greater chance of capturing small intestine bacterial overgrowth if it is there. Now, what I've heard from some clients is they say, well, Jillian, that's, great and everything, but my gastroenterologist says that, the tests are not accurate for small intestine bacterial overgrowth. All right, this is very silly because the sensitivity and specificity for these tests are at least 85 to 87% accurate. This is on par with virtually every other blood test or any other functional type of test that you could think of. So that is a misnomer. That's inaccurate, and I feel like that's something that is just sort of repeated over and over. The tests are extremely helpful and are going to capture almost 90% of cases. To me, this is not worth abandoning the test for that. All right? I'm going to give you a couple of tips to prepare yourself for a breath test. I have my clients start their tests in the morning when they wake up. You want to be fasting, all right? You don't want any food on your stomach. For 2 weeks prior to your very first test, this would be an initial test for small intestine bacterial overgrowth, right? So this is not like a follow-up test to see if it's gone. This is your very first test. For 2 weeks, you do not want to be taking antibiotics, all right, because this can sway the test. For 1 week, you don't want to be taking any probiotics, or you don't want to be taking any herbs that have antimicrobial, meaning antifungal, antibacterial activity. 2 to 3 days before, you don't want to have any fermented foods, okay? No yogurt, no kimchi, no sauerkraut, no kombucha. You want to just be eating really sort of plain, like your normal foods, all right? Then you go to bed, you wake up in the morning, you don't have your breakfast, and you begin your test. This is going to offer a very clean slate, right, to actually challenge and see if there are bacteria that make hydrogen and methane in your upper gastrointestinal tract. Your upper gastrointestinal tract includes your stomach and your small intestine. All right, so some of you might be thinking, well, okay, what about other testing options? And there are some. You may have heard about intestinal aspiration. This is where you do have to go in for this one. Your doctor will thread a tube down your throat and through your stomach and suck out the contents of your small intestine and then take them to the lab and count the bacteria that are there. If there are greater than normal levels of bacteria, then that's diagnostic for small intestine bacterial overgrowth. However, there are a couple problems with aspiration. One, it's invasive because you do have to go in and have a tube introduced into the upper GI, which is not fun or whatever. But also, with this aspiration, the doctor's only sampling a couple spots in the small intestine. And they're doing it more proximally, right? Closer to the stomach, more in the duodenum, right? So you are missing, because they're not going to thread a tube 40 feet down your small intestine. So you're missing those later, further, or more distal portions of the small intestine. So for the reduced sample size and for the reduced sample area, I am really not a huge fan of aspiration, not to mention its invasiveness. All right. Then I also get a lot of questions about, well, what about blood testing or urine testing? There's a type of test called the OAT test, the organic acid test. And this is a urine test. And while it can detect the presence of harmful bacteria, their metabolic byproducts, it cannot pinpoint where the bacteria are. Okay? Are they in the upper GI? Are they in the small intestine? Or are they in the large intestine? We don't know. It's the same with a stool test. I am a very huge advocate of stool testing for a variety of reasons. Stool testing can detect all types of dysbiosis. Dysbiosis simply means an imbalance of good, normal, healthy bacteria. It can be low numbers of good guys, it can be high numbers of bad guys, it can be a frank infection, or it can be an overgrowth where bacteria don't belong. But like a blood test, if you're simply looking at the stool, because that stool has traveled the entire length of your gastrointestinal system, you cannot, again, pinpoint where that dysbiosis is coming from. Thus, the breath test isolates the small intestine and the upper GI tract specifically and sort of exquisitely. What's more, we also know, even in a slow motility state, about how fast we would expect these sugars to track themselves through the small intestine. So this makes breath test your best option in my mind, and I think you're going to get the most clinical relevance. And in the United States, these tests are between $150 and $160. So they are not cost prohibitive either. So I really like breath testing for that reason as well. Some tests can be very, very expensive. A stool test is going to be close to twice that, all right? So stick with your breath test. You want to ask for a lactulose test, and you want to do your prep for your breath test. Before I move on to treatment, which is sort of like the juicy part of this whole talk, I want to make it clear, or at least known to you, that at least 30% of small intestine bacterial overgrowth also has another type of overgrowth riding along with it. And this is called small intestine fungal overgrowth. So it is entirely possible for, in addition to bacteria being overgrown in the small intestine, that you also have other non-beneficial / harmful microorganisms there. This is another major reason for why treatment either fails to work or why relapse rates can approach 30 to 40%. It's because treatment, we focus on antibiotics, which only work on bacteria and don't work on fungus, yeast, and other microorganisms. All right, so up to 30% can also have SIBO, small intestine fungal overgrowth. And I want you to keep that in mind as we move into the treatment section of things. Because when we look at treatment from a very broad, comprehensive, integrative approach, we want to be able to address that. So, like I mentioned, relapse rates. Relapse means you get treated, you feel better, but then within months or a year, you're back to where you started. It's called a relapse. Or you also can have failure rates where you're treated, but you're not getting better. You're treated appropriately with the appropriate antibiotic, but you're not getting better. These happen for a couple different reasons. One is the biofilms that we discussed, right? That fortress that protects against treatment, the fortress that the little bugs make. Second is because we may have overlooked the fact that the bugs that are in our small intestine aren't all bacterial. And then also we can look to other factors like our nutrition, because there is indeed a very specific nutritional approach to at least start with. All right? So with that all laid down and outlined, let's talk about how to approach treatment. Treatment is also broken down into several different chunks, all right? So here's how I'm going to do it for you. First, we have our conventional approach, right? I'm going to cover this in depth. And then we have our integrative add-ons. In my clinical experience, I've been working with this for 11, almost 12 years. We want to approach this using conventional and natural methods. The two together are what yield the best results because they are covering all of those bases that are responsible for relapse. They are covering the fact that there might be fungus or yeast present. They're covering biofilms. They're covering the fact of the slow environment of the small intestine. So here we go. First, we have a nutritional approach. Next, we use supplemental digestive enzymes. Next, we use natural antimicrobials, natural antibiotics as it were, that are going to kill not only bacteria, but also yeast and also archaea. Remember, I mentioned archaea as one of those non-bacterial organisms that produces methane. All right, so we can get clues for how we want to approach this also, whether you have a hydrogen positive breath test, a methane positive breath test, or both. After your antimicrobials, your natural antimicrobials, there are still two other main factors that we want to pin down. First is the biofilm buster. All right, it's extremely important for us to break up these biofilms so that our antibiotics and our antimicrobials can be delivered directly to the infection. If we are not breaking up biofilms, and biofilms are present, and by the way, biofilms are present in estimated in up to 90% of cases, then we're gonna have a real issue there. We're gonna have higher rates of relapse, higher rates of failed treatment. And then we also want to add in what's called a prokinetic agent, all right? A prokinetic agent is one that helps reestablish the appropriate movement of the small intestine via helping or tuning up that dysfunctional migrating motor complex, right? So a major way to prevent relapse is to get the small intestine moving at the right speed, yeah? Not too fast, not too slow, because it's that slow environment that sets the stage for adhesion and colonization and overgrowth to occur, right? And then we've got the biofilms, and then we've got the symptoms, and so, then we go on and on and on. All right, so those are the main categories. A category that happens or that we bring into treatment on an individual basis is the use of probiotics. Usually, when I'm working with someone, I don't start with probiotics right out of the gate. This is because a lot of people with small intestine bacterial overgrowth don't tolerate probiotics well, right? But also because I want to do a really good job killing off the bad guys. I also want to be clear that probiotics do not cause small intestine bacterial overgrowth. They can worsen symptoms, they can stir things up and exacerbate things, but they're not going to actually cause the condition, right? The condition is caused by the slow small intestine and those defenses being breached, okay? So you're not gonna get small intestine bacterial overgrowth from drinking kombucha or from taking your probiotics. But probiotic treatment right out of the gate can complicate matters. So for this reason, for the most part, I don't lead with it. Probiotics and compounds that help heal the lining of the GI tract, these tend to come later after we complete a killing protocol. A killing protocol is what I'm going to describe to you right now, which just basically means like, how are we going to treat this infection? All right, so let's start back at the top. Conventionally, the antibiotic that is used to treat small intestine bacterial overgrowth is called rifaximin. Rifaximin is a unique antibiotic, all right? When we think about antibiotics, we think about all those nasty side effects, right? They're killing all of your good guys. They're giving you stomach pain. There's antibiotic-associated diarrhea. There's C. diff infection. Rifaximin is, it's bile soluble, okay? So its greatest activity is in the small intestine, right? Because most of the bile is resorbed. 95% of it is resorbed back into your body before it hits the large intestine. So in this way, rifaximin is extremely well tolerated and has far, far fewer side effects and a much lower adverse risk than other antibiotics like clindamycin or doxycycline or, all of those other guys. So rifaximin probably is my favorite antibiotic for this reason. All right, and to crunch some numbers there, you've got like a less than 2% chance of having an adverse reaction to rifaximin versus 10 to 30 times that for other antibiotics. All right, so this is an antibiotic that's very safe, mostly safe, right? Safe enough that I'm very comfortable recommending it to you and talking to you about it now. Now, rifaximin is taken for, there's essentially 3 different treatment options. You can take a higher dose for 7 days, a lower dose for 14 days, or sort of a medium dose for 10. All right? Now, from an integrative perspective, but before I go there, sometimes, based on your history or your symptoms, rifaximin can be combined with other compounds that might have antifungal actions as well, like metronidazole or ketoconazole or nystatin. These are antifungals. These have slightly higher adverse risk profiles. Ketoconazole can be very bad for the liver, but if you have other signs of fungal infection, or if you have also done something like a breath test, or an oat test or a stool test to determine that yeast is present somewhere in the gut, your doctor might want to layer those in as well just to cover their bases. All right, so sometimes those two are combined. Now, from an integrative perspective, how I treat small intestine bacterial overgrowth and how I would suggest you approach it is, in addition to the rifaximin, the conventional antibiotic, we're going to do all of these other things. The major difference is that we use all of the dietary and natural approaches for 12 weeks, for 3 months. All right, so this is kind of a process, but it also is going to yield you your greatest results and get you feeling better faster and going to reduce your rates of treatment failure and relapse. So ideally, you would begin your conventional rifaximin treatment at the same time that you begin all of your integrative approaches as well. Then, after that 7 to 14 days on rifaximin has passed, you continue on with all of these other approaches I'm going to lay down for you until 12 weeks has passed. All right, so you've got a week or 2 overlap with the antibiotics, and then you've got up to 12 weeks for the integrative stuff. And here we're going to talk about the integrative stuff. First, we're going to talk about nutrition. The most studied dietary approach to small intestine bacterial overgrowth management is a low FODMAP diet. FODMAPs are an acronym. They stand for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. This is just a very fancy way to say that certain types of carbohydrates and fiber are very fermentable, aka gas-producing, to bacteria, particularly a dysbiotic flora or a flora that is high up in the GI tract. So I would have you Google or look up low FODMAP. There's tons of resources on the internet, on my website. There's even an app called Monash University Low FODMAP. FODMAPs are found in an enormous variety of vegetables, fruits, grains, and dairy products, and legumes. All right, so things that are healthy, broccoli and cabbage and apples and onions and garlic and melon and apricots, right? All of the good things. So you want to be emphasizing foods that are low on that FODMAP scale. I usually have people aim for about 85% low FODMAP. Once you begin to familiarize yourself with foods that are low FODMAP, this actually becomes quite easy and automated. All right, so a low FODMAP diet is your first step from the dietary approach. I also want to mention that in cases of long-standing small intestine bacterial overgrowth, sensitivity to histamines, salicylates, and oxalates are common. So if you're not getting anywhere with FODMAPs, I want you to look into those as well. All right, histamine, salicylates, and oxalates. But start with your low FODMAP diet first. There's plenty of delicious foods that are low on that FODMAP scale. Next, the reason why we do low FODMAPs is to essentially begin to starve the bacteria that live in the small intestine. In turn, this is going to reduce the gas and bloating and reflux and discomfort that you feel within that 20-30 minutes of eating. Next, you want to take a digestive enzyme with meals when you eat. What the enzymes do is they are helping to break down proteins, fats, and carbohydrates. Breaking these things down into teeny weeny little ready to be absorbed particles helps reduce fermentation and gas and bloating and discomfort, and also helps reduce an immune system response, like an overactive immune system response. When certain food compounds aren't broken down appropriately, it catches the attention of the immune system in a bad way, not in a good way, right? So when you eat your low FODMAP foods, you want to take your enzymes with them. Look for an enzyme that has these things in it: amylase, protease, lipase, and pepsin. Enzymes are inexpensive and very safe. It's essentially impossible to take too many. They help break down in the stomach, right? So I would take 1 to 2 with meals. So we've got our low FODMAPs, we've got our enzymes. Next is you want to take a natural antimicrobial. So this, now we fall into the area of herbs. There are a wide variety of herbs and herbal formulas that are effective against bacteria and fungus and yeast and archaea. This is why herbs are amazing, because unlike an antibiotic that is just working against bacteria, the herbs have the potential to work against all of the microorganisms that are causing your distress. So there are several herbs that would fit the bill here. And you can try herbs singly, meaning like one herb at a time, or you can try formulas of different types of herbs. There are several formulas that I like. One is a liquid formula. It's called Biocidin, and the dose is 1 drop per 10 pounds of body weight, right, per day. There are also a number of individual herbs that I can list off a few of them for you. Berberine, Oregon grape, garlic, pomegranate, oregano, neem, the quebracho tannins, like all of these guys have broad-acting antimicrobial activity. How I dose natural antimicrobials is preferably on an empty stomach, okay, twice a day. So if you're using the drops like Biocidin, you would take your body weight, divide it in half, convert it to pounds, and then those are the amount of drops you take, half of that in the morning, half of that in the evening, preferably on an empty stomach, unless it makes you nauseous. If it makes you nauseous, take it with food, okay? The other thing to know about the natural antimicrobials is every 4 weeks, I switch them up. Whether we swap to a different formula or maybe an individual herb, you want to keep rotating every 4 weeks, so that'd be a change of guard 3 times, to help increase sensitivity and promote resistance. Essentially, you're going out and you are trying to destroy as much of the infection from as many angles as you can, all right? Twice a day, preferably on an empty stomach. When you take your antimicrobials, when you're taking rifaximin, I also recommend taking the two together, all right, or 30 minutes apart or so. When you take your natural antimicrobials, I also have people take a biofilm buster, all right? Remember biofilms? Those little fortresses? We need to break that up so those amazing antimicrobials can be delivered to the infection. Biofilm busters are made up of a variety of enzymes and chelating agents that help penetrate and dismantle and disrupt that biofilm layer. I use a product called Interphase Plus by Claire Labs, and I have people take 2 capsules twice a day alongside their natural antimicrobials and their rifaximin when and if they're taking rifaximin. All right, the biofilm buster is a guard against treatment failure and relapse, right? Lastly, that last sort of piece that I always do is the introduction of a prokinetic agent. And again, prokinetics are certain compounds that help reestablish appropriate movement of the small intestine and the migrating motor complex. Okay, so my favorite prokinetic agent is one called Iberogast. You can find this on Amazon. It was developed in Germany. There are multiple studies that show that Iberogast is just as effective as many of the conventionally prescribed prokinetics. Conventionally prescribed prokinetics are low-dose erythromycin, low-dose naltrexone, right? I prefer the natural stuff. So I will have folks take 2 teaspoons to 1 tablespoon, depending on body weight, right? So if you're a tiny, petite woman, I'd have you do 2 teaspoons. If you are a larger man or a larger person, I would have you take full tablespoon at bedtime, okay? Bedtime. And that is the outline for my approach to treat small intestine bacterial overgrowth. I want to say a couple words about probiotics, all right? Probiotics could be introduced at about the 8-week mark of the killing protocol, or they could simply be introduced at the end. You want to think about your history and your tolerance when thinking about probiotics. If you have a history of food poisoning or lots of international travel or lots of rounds or courses of antibiotics, you're probably a really good candidate for reintroducing probiotics, which are essentially the healthy form of beneficial bacteria, into your system, because they will help your normal healthy flora reestablish itself, which not only is going to protect against relapse rather, it's also going to help your immune system and your overall digestive function. When you consider probiotics for small intestine bacterial overgrowth, where the research tends to be drifting to are something called soil-based organisms, all right? These guys are a set of bacteria that are spore-forming, meaning this is a form of like survival versus reproduction. So there are a couple different probiotic products in the United States that have soil-based organisms. So Prescripticist is one, and there's also, it's called Garden of Life. They have a soil-based organism probiotic as well. So for probiotics, introduce around 8 to 12 weeks if you have those that prior history, and if you have not experienced negative side effects from probiotics. If you take probiotics and they are restarting your symptoms, stop. Okay? So this is not like terribly difficult to sort out. They are not absolutely required, but they can be extremely beneficial. Likewise, at the end of your 12 weeks, after our 12-week killing protocol, there's good reason to do about a month of a gut repair complex or product. This is because as all of those microorganisms are dying off, they're releasing distress compounds, they're releasing their normal metabolic byproducts, they're releasing the contents of their cell walls. All of these are highly irritating to the lining of the gut and stimulating to the immune system. So by using a gut repair product at the end, it's almost like we're going in and kind of cleaning up and mopping up the damage from the killing protocol. So glutamine is a major healer of the lining of the small intestine. I recommend a dose of anywhere between 3 to 4.5 grams a day. There are other products that have a variety of glutamine and other herbs and compounds that help heal that small intestinal lining. There are two that I really like. One is called GI Revive by Designs for Health, and one is called Repair Vite SE by Apex Energetics. And you would just follow the label of how to take those. And those help clean up the lining of the small intestine. So those last two pieces, probiotics and gut lining repair, are sort of optional after the fact things to think about that are going to depend on your history and where you are at. All right? You also, at the end of this treatment protocol, you can begin to reintroduce one by one high FODMAP foods that you are missing, that you haven't been eating rather. And normally how we do this is one at a time, every 3 days, to see how your body responds. Some people are able to reincorporate a wide variety of those foods that they've eliminated, and some folks are not able to, or they're not able to for some months or even a year later. So I would recommend that if you are not able to reintroduce those foods, you can maintain the low FODMAP diet and strategically and sort of periodically challenge those things back in. Also, I can't say enough about getting rest and getting movement, right? Going for a walk, stretching, doing some exercise sessions throughout your killing protocol to help your body and your nervous system relax, because this, and sort of de-stress, because this helps balance your second brain, which in turn helps balance and restore function to the migrating motor complex. Not to mention the extremely intimate connection between our mind and our brain here and the brain that resides in our gut. That, however, is a subject for a whole other talk of how we can de-stress our guts. But I do want to mention it because I'd be amiss not to. All right, loves? So that is a crash course in small intestine bacterial overgrowth. Thank you so much for listening. Thank you so much for watching. And you can find me on the internet. My website is www.jillianteta.com. If you need more information, I have tons of free resources and blogs and programs. My book is on there, social media, all of those things, all right? Thank you guys so much for watching. I will see you soon. Bye.